This video is on COPD, which is chronic obstructive pulmonary disease. It is a commonly seen progressive disorder characterized by obstruction of the airway. FEV1 less than 80% predicted, or FEV1 to FVC ratio less than 0.7. There is little or no reversibility, and COPD includes lung diseases, for example, chronic bronchitis or emphysema. Chronic bronchitis is defined clinically as coughing and sputum production on most of the days for 3 months of 2 successive years. Whereas emphysema is defined histologically as enlarged air spaces distal to terminal bronchioles with destruction of the alveolar walls. Here are some features suggestive of COPD. If the patient is more than 35 years old, is a smoker, especially chronic smoker, has chronic dyspnea where there is shortness of breath, sputum production, and also minimal diurnal or day-to-day FEV1 variation, as this is more suggestive of asthma. So if minimal, it can help to rule out asthma. The symptoms of COPD include coughing, especially chronic cough, sputum, dyspnea, and also wheezing, where there is a sound during expiration, a whistle-like sound. The signs of COPD include vital signs like tachypnea. On inspection, we can look for the use of accessory muscles and a hyperinflated chest, also known as barrel chest. On palpation, take note of reduced cricosternal distance. Normal is 3 cm. If there is reduced, it's less than 3 cm. We can measure this by using 3 finger breaths. There will also be reduced chest expansion. On percussion, it is hyperresonant on percussion due to the hyperinflated lungs, and there will be loss of cardiac and liver dullness. On auscultation, there will be reduced breath sounds. To investigate for COPD, can do full blood count, where we expect to see high PCV, polycythemia. On chest x-ray, look out for signs of hyperinflation, which are more than 6 anterior ribs seen above the diaphragm, in mid-clavicular line, a flattened hemidiaphragm, enlarged central pulmonary arteries, and also reduced peripheral vascular markings. These are the signs of hyperinflated lung seen in COPD. For another investigation is ECG, look for signs of coro pulmonale. And we can also do lung spirometry to look out for obstructive pattern and air trapping to confirm COPD, which is an obstructive lung disease. If it is restrictive pattern, it might suggest for other lung conditions. This is the goal staging for severity of COPD. There are stage 1, 2, 3, and 4, which are mild, moderate, severe, and very severe. So the FEV1 to FVC ratio are all the same, which is less than 0.7. So for this goal staging, we will take a look at the FEV1. For stage 1, which is the least severe, the FEV1 will be 80% or more. Stage 2, 50 to 79%. Stage 3, 30 to 49%, and below 30%, it will be very severe. So here we can see FEV1 is the forced expiratory volume in the first second, whereas FVC is forced vital capacity. For treatment of COPD, it depends on the severity. General management, we ask the patient to stop smoking as it exacerbates the disease, encourage exercise, and we can also give preventions like prevention of infection by giving vaccination of influenza and pneumococcal vaccines. For mild or moderate disease, we give inhaled tiotropium or beta-2 agonists. Severe, we can combine beta-2 agonists with corticosteroids. And if there is pulmonary hypertension, we assess the need for LTOT, which is long-term oxygen therapy. This is the treatment for advanced COPD. So we can consider for long-term oxygen therapy, or there are also some indications for surgery that can be done. Let's take a look at the long-term oxygen therapy. So the partial pressure of oxygen will be maintained more than 8 kPa for 15 hours a day. And some of the indications to give this LTOT are listed over here, which include clinically stable non-smokers with PaO2 less than 7.3, or if the PaO2 is less severe, which is 7.3 to 8, but they have pulmonary hypertension or these other signs and symptoms, we can give LTOT because it is severe disease. And another indication is for terminally ill patients. COPD is very severe progressive disease, and here is the list of complications that could occur. So COPD patients, they might have acute exacerbations of COPD due to infection, can have polycythemia, respiratory failure, cor pulmonale, pneumothorax, and might also progress to lung cancer. For prevention, we can give pneumococcal and influenza vaccination to prevent disease that exacerbate the condition. That's all for this video. Thank you.